So hello, everyone. My name is Caitlin Vafislawski, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our first educational session of the day, which will focus on COVID-19 and vaccine information and updates for patients with lymphoma and CLL. We appreciate so many of you being able to join us online today. The COVID-19 pandemic has brought many challenges to the lymphoma and CLL patient community and their caregivers. Whether you are newly diagnosed or currently receiving treatment or even a lymphoma survivor, this webinar will provide you with information about the impacts of COVID-19 for lymphoma patients at different stages of their care. Available information and research about the COVID-19 vaccines for lymphoma patients will also be shared. Before I go ahead and introduce today's speaker, there are just a couple of items to note. This session is being recorded and the recording will become available following the conference. You will receive an email at the time that the recording becomes available. At the end of this presentation, we will leave about 5 minutes for a question and answer period. To ask your questions, you can type them into the questions box, which is located in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. I would now like to introduce and welcome our speaker for today, Dr. Hosseini. Dr. Hosseini received his Master's of Public Health in Epidemiology and Biostatistics from Western University and finished his training in the specialty of infectious disease and tropical medicine, as well as oncology, transplant, and infectious disease specialties. He was the Director of Transplant Infectious Disease at London Health Sciences Centre and is now an Associate Professor of Medicine and Transplant Oncology as the Infectious Disease Fellowship Director at the University Health Network. Dr. Hosseini provides his expert guidance and information following his research and work he has done related to the COVID-19 pandemic. Thank you very much for joining us today. I would now like to go ahead and turn over the presentation to you. Thank you very much, Dr. Hosseini.
Thank you so much. So today we will review some updates related to the current pandemic of COVID-19, and specifically we will look at issues that are related to patients with lymphoma and chronic lymphocytic leukemia, CLL. This is my slide of disclosure. As you know, current pandemic of COVID-19 is caused by a virus called SARS-CoV-2. This is a coronavirus. It is a virus very similar to bats coronaviruses, those viruses that are circulating among bats. It is not that much similar to SARS-CoV that caused the pandemic around 20 years ago, SARS pandemic. It binds to our human cells, to a very complex molecule. It's called ACE2, angiotensin converting enzyme 2, and then enters the cells and causes progressive illness, progressive pneumonitis, inflammation of the lung, and severe illness if we cannot stop progression of the virus. Probably you heard a lot about the variants of this virus, variants of SARS-CoV-2. We briefly review this issue together. We have different terms about variants, variants of interest, variants of concern, variants being monitored. The thing that is important to know about is variants of concern. One of the problems with this virus is the huge rate of mutations that we noticed since the first, initial 3 or 4 months that this virus was circulating in China and then around the world. This is unexpectedly high in terms of genetic changes that we observe in this virus. So we have to do everything that which is possible to stop, progression of this virus and specifically circulation of the virus in the community. Most mutations do not affect the function of the virus, do not affect the behavior of the virus. However, some mutations, some genetic changes are able to change the function of the virus. The virus becomes different in terms of transmissibility, in terms of illness and severity of the disease, and unfortunately, mortality. If a variant is able to cause some changes in transmissibility of this infection or causes a more severe illness, means a higher rate of hospitalization or admission to ICU, or a higher rate of death, or the previous immunity that people have from, infections with this virus 3 months ago, 4 months ago, or they received vaccine and they have some immunity, and the variant is able to escape from previous immunity, or if our routine tests are not able to detect this virus, it is called variant of concern, VOC. We will talk about these variants of concern briefly together, and of course at the end I will be happy to answer your questions. The first variant that I wanted to discuss about is alpha variant that became common in Canada initially. This variant was able to cause a higher rate of transmission. Transmissibility was 45 to 80% more than other isolates of this virus. It caused a higher rate of hospitalization, more severe illness, and unfortunately a higher rate of death. However, people that they had immunity against this virus with vaccine or with previous infection, they were relatively protected, and it did not affect that much the immune response to the virus. The second variant, which is called beta variant, is a variant that was initially detected in South Africa. It did not expand that much beyond Africa. We were able to detect this variant, I don't know, other parts of the world, but the rate of expansion was not similar to alpha variant. It caused a higher rate of transmissibility, means an infected person was able to cause more infection to the other people in the community. It didn't cause significant change in terms of severity of illness and rate of ICU admission or mortality and death. However, important thing with this variant was the main characteristic that was found in the studies at that time was the ability of this variant to escape from previous immunities that people had. This is called immune response evasion. Means this variant was able to relatively escape from previous immunity. The third variant was initially detected in Brazil and Japan. Is called Gamma variant. You may know this, you may see this in the news as P1 variant or P2 variant. This variant also did not seem to cause a higher rate of transmissibility or severity of the illness. However, similar to beta variant, gamma variant was also able to escape from previous immunities and cause immune response evasion, less than beta variant, but had this ability. The fourth variant that we want to discuss about that today, variant of concern, is Delta variant. That is the most prominent variant around the world, including Canada. It has a huge rate of transmissibility and unfortunately causes a higher rate of severe illness, hospitalization, admission to intensive care unit, even mortality. Previous immunities that people had with vaccination or previous infection with SARS-CoV-2, it may protect them from infection with this VOC or variant of concern. People who have a history of vaccination, they will be protected against severe forms of COVID-19, means they are quite unlikely to get hospitalized or go to ICU or they die with COVID-19. However, they may get some symptomatic illness. They may develop fever, they may develop sore throat, runny nose, cough, but usually the disease is not that severe that causes mortality or requires admission to hospital or ICU. When we talk about transmissibility of the virus, what exactly happens? What is the mechanism? When a virus, keeps changing the genetic materials and the genome of the viruses, changes a lot, you may see some adaptation in the virus in a way that the virus is able to progress more and replicate more in the human tissues, in the lungs. When the number of viruses, go up, we call it as increasing of viral load, person becomes more contagious to other people. You see a higher rate of transmission to other people. Or some variants like this specific mutation that was detected in alpha, beta, and gamma variant was able to bind more efficiently to human cells, 10 times more tightly. So when you have more efficient connection between the virus and human cells, you have more progressive illness, you have more damage to the lung tissues, and of course, more contagiousness. And the third characteristic is immune evasion. Those variants, those viruses that are able to escape from the immune system, of course, antibodies and immune response of the person who was infected is not able to control the replication of the virus. Again, number of virus goes up, and then cause more progressive illness and more contagiousness. What is the current situation of COVID-19 pandemic in Canada as of October 2021? As you see in this slide, we are in this wave of pandemic, which has been unfortunately getting worse week by week. And every week we see, different numbers. I was looking at the data, like today I saw more, focused number of patients in Alberta. We will review that together. In this slide, as you see on the top in the left, you see the number of cases in Canada gradually was increasing. The magnitude of this wave, current wave, is of course less than magnitude of the previous waves that we experienced in Canada. But it's interesting that the frequency of infection in Canada is not similar in different provinces and different territories. For example, in Yukon, in Prince Edward Island, in Nova Scotia, New Brunswick, in Newfoundland, you don't see that much activity. It is interesting to see in Alberta, the magnitude of the wave is very similar to previous waves. So it is a very significant, change and rising of the number of cases in this specific area. In Ontario, the magnitude of wave is less than previous waves, but remember, the number of people in this province is 10 million more than Alberta. So even lower magnitude of this wave here, it may show a lot of patients. In many weeks we saw similar number of patients in Ontario and Alberta. In Quebec, we see a relatively decreasing pattern of the number of infected people with SARS-CoV-2. This is good, but still we see around relatively noticeable number of cases in this province as well. So when you see this map, it is interesting that the activity of the virus and pandemic is not similar in different areas and different provinces in Canada. For example, in Newfoundland, the activity is very low. In Quebec, Ontario, Manitoba, and Saskatchewan, activity is lower than Alberta and British Columbia. If you look at the data, it was just published today, the magnitude is much higher in Alberta, even more than British Columbia and Northwest. Generally, we were seeing around 4,000 new cases almost every day in Canada. Almost all of them are VOC, variants of concern. 99% of infections these days are Delta variant that we just reviewed together. Unfortunately, we had around 140 deaths every week because of COVID-19, and this pattern has been rising, as I just explained. This new wave caused around 2,000 hospitalization every week, and we had more than 600 intensive care unit admissions in average. Why people get infection when we have relatively, good number of vaccinated people in all provinces, across Canada and all territories. This slide is actually eye-opening to show a current situation of COVID-19 in Canada. As you see, when you look at the number of cases with COVID-19, the percentage of cases with COVID-19, considering their vaccination status, more than 85% of people, they are unvaccinated. And only 4% of people who got vaccine, they're fully vaccinated, 2 doses, and 15 days passed from the second dose of vaccine. Only 4% of people who got COVID-19 were fully vaccinated. But relatively the same situation you have when you look at hospitalizations secondary to COVID and mortality secondary to COVID. Again, around 80-85% is related to unvaccinated people, and again 3%, 4% is related to fully vaccinated people. These two groups are people who are partially vaccinated or just started getting vaccines. So the vaccines are still very effective against Delta variant and was helping us. Otherwise, these numbers was much higher than this. Is COVID-19 more severe in patients with chronic lymphocytic leukemia, CLL, and lymphoma? The answer is yes. Overall, it appears that cancer increases the risk of severe illness with COVID-19. However, in many data, they showed, there are other variables that are playing roles in terms of epidemiology and expansion of this pandemic and severe illness in our community. For example, if you look at other risk factors for severe illness, you see diabetes, you see age older than 65 years, you see underlying kidney disease, you see high blood pressure. There are other factors that they also increase the risk of severe illness. So many people with cancer, they also have other comorbidities like high blood pressure. So we are not 100% sure. Some data said this may not be only cancer that's causing, a higher likelihood of getting severe illness, maybe other factors too, which is true. But there is no clear data to show, which type of cancer is more associated with severe illness. Current literature that we have and current data that we have, it appears that people with leukemia, CLL, and lymphoma, and in solid tumors, lung cancer, they are more likely to develop severe illness. Again, we need more data to have a better explanation for this. Who needs to be tested for COVID-19? Whoever develops symptoms of COVID-19, fever, cough, sore throat, runny nose, they are possible to be infected with SARS-CoV-2, and it is better to be tested. Whoever has a history of exposure to non-case of COVID-19, it is better to be tested, even if fully vaccinated. Even if has no symptoms, it is better to be tested for COVID-19. People who are asymptomatic and they are supposed to start immunosuppression, your doctors will tell you it is better to be tested prior to immunosuppression. People who are getting chemotherapy, people who are supposed to get stem cell transplant or CAR T-cell therapy, cellular immunotherapy, long-acting biologic therapies like rituximab or high-dose corticosteroids, they are better to be tested for COVID-19 prior to treatment. And whoever is needed to undergo cancer surgery, it is also better to be tested for this specific viral illness. Some people, they are interested in doing some antibody tests and serology tests to check their immunity against COVID-19. We do not recommend doing these types of serology tests or antibody tests. Why? Because many of those tests that are available, they are not standard. We use them in research projects, but not necessarily for people in the community. Most of the studies showed People with lymphoma and CLL, they may not develop good level of antibodies, and then the level of antibodies may go up, may come down. We don't know exactly the meaning of those changes in the level of antibody. Some data that they looked at antibody production after COVID-19 patients with CLL and lymphoma, they found around 60 to 70% of those individuals, developed antibodies against SARS-CoV-2 or COVID-19. It was the level of antibodies was not necessarily related to chemotherapy. People who were or were not on chemotherapy, their immune response to this virus was not great. The reason seems to be clear because most people, they had this issue. We call it as hypogammaglobulinemia, means the level of antibodies was low anyways against other viruses, other bacteria. So that's why they are more susceptible to get sinusitis, to get pneumonia, and SARS-CoV-2 also causes lung infection. Let's talk about vaccination in patients with lymphoma and chronic lymphocytic leukemia, CLL. Overall, we recommend COVID-19 vaccine for everybody. It is better to get vaccinated and remain protected against COVID-19, at least severe forms of COVID-19. Immunogenicity means immune response to vaccine may be relatively lower than general population. It was shown in many studies that the level of antibodies and the frequency of developing antibodies was lower in patients with CLL and lymphoma. People who are supposed to get HCT, hematopoietic cell transplant, like a stem cell transplant, or CAR T cell therapy, which is a very good treatment these days for people with lymphoma, we asked them to wait for 3 months and then they get COVID-19 vaccine, because initial months after CAR T cell therapy and stem cell transplant, their immune system function is generally low, and if they get vaccine, the vaccine may not work. We always prioritize, people who received stem cell transplant or cellular therapy, like CAR T cell therapy, beyond 3 months to get their vaccines faster because their immune system function is lower than other patients. People who are supposed to start treatment like chemotherapy, I'm not talking about hormonal therapy that does not increase the risk that much. They also need to get COVID-19 vaccine, but if we want to prioritize people who need to get vaccine, these are a group of people that they are better to get vaccine sooner, and people who are older than 65 years, generally with or without cancer, they are more likely to develop severe illness with COVID-19. There are some data like this paper that I mentioned here that specifically looked at the efficacy of vaccines in patients with CLL. This is the data that looked at the efficacy of Pfizer vaccine. This is BioNTech vaccine, Pfizer vaccine. Around 170 patients, they received 2 doses of vaccine. And then they looked at the level of antibodies, like immune response against the virus 2 to 3 weeks after the second dose. Unfortunately, the rate of response was something around 40%. Then people who were using specific group of drugs, we call it as Bruton's tyrosine kinase inhibitor, ibrutinib, for example, or acalabrutinib, the rate of response is even lower, was around 16%. Some patients may receive venetoclax or rituximab. The rate of response was even lower, something around 14%. So this data shows vaccination in patients with CLL is very important, but it is better that they, still consider social distancing, wearing masks, frequent hand washing to remain protected. What about these two specific types of treatment, stem cell transplantation and also CAR T cell therapy that are used for management of lymphoma and CLL. Sometimes this data looked at the frequency of people who had a response to COVID-19 vaccine. This study showed that around 75% of people who received allogeneic stem cell transplant, means the stem cell transplant came from a donor, not from patient herself or himself. So this group had around 75% response rate against COVID-19 vaccine. When they looked at CAR T cell therapy, the response to vaccine was even lower, around 36%. But when they looked at magnitude of the antibody and how much antibody was produced, when we say these people had a response to vaccine, you see the response was relatively poor in people who received CAR T cell therapy, and in patients with allogeneic stem cell transplant was much better. Most of these people, they were transplant patients beyond the second year after transplantation. The first year after transplant, the response to vaccine may not be great. Let's look at people with non-Hodgkin lymphoma, Hodgkin lymphoma, and CLL. This is another study that they looked at CLL patients and people with two types of lymphoma, and they measured their immune response to Pfizer vaccine, BioNTech, and then with two specific tests that they are FDA approved and they are very valid tests. They saw non-Hodgkin lymphoma patients, when they get the first dose, their response is poor. When we look at their immune response 2 or 3 weeks after the second dose of vaccine, you see the response rate was something around 22%, was not great. The situation was much better in patients with Hodgkin lymphoma. Their response after second dose was similar to general population, but in CLL patients, similar to non-Hodgkin lymphoma patients, the response to vaccine was again low. If I want to summarize the thing that I said about vaccination in lymphoma patients and CLL patients, it is better to consider these 10 important points. Lymphoma patients and CLL patients, they may experience a higher level of antibodies if they test their blood against SARS-CoV-2. Patients with non-Hodgkin lymphoma and CLL, usually they are expected to have a suboptimal response to vaccine, means the frequency of response to vaccine and the magnitude of the antibodies may not be that much great. Antibody titers are lower than the thing that we saw in general population. Durability is another thing that we have to consider, because if you follow these patients 3 months later, 4 months later, you will see the level of antibodies drop more than expected. People who are on treatment for lymphoma, they may have a lower response to vaccine. Vaccination has no impact on treatments. Many patients, they ask us if they receive vaccine, it may cause a problem for the treatment for CLL or lymphoma. It is not true. Vaccination against COVID-19 has no impact on treatment of CLL or lymphoma. It is important to know that fully vaccinated does not mean fully protected. If you received 2 doses of vaccine or even 3 doses of vaccine, you should still, consider the social distancing and wearing masks and other measures to reduce the risk of infection. And antibody testing, as I just explained, it is not recommended for several reasons that we just reviewed together. And patients with CLL and lymphoma do not necessarily have a higher rate of adverse effects, side effects when they receive vaccine. This is the study that they looked at people who received a COVID-19 vaccine. They compared patients in cancer cohort. Around 40% of these patients, they had lymphoma or CLL, and then compared their adverse effects with healthy controls, means general population. As you see, whatever adverse effect that you consider, it appears that the frequency of that adverse effect was much lower in patients with cancer. So we can say the risk of having side effects of vaccine in cancer population is not more than general population. What about the third dose of vaccine? This is my last slide. We do recommend the third dose of vaccine at least 28 days after the second dose. We only recommend mRNA vaccines, means Pfizer or Moderna vaccine. Most patients with lymphoma and leukemia should receive the third dose of COVID-19 vaccine, which will likely causes a higher rate of immune response. We are doing the studies here, and preliminary data shows the response to vaccine will improve when they receive the third dose of vaccine. People who are receiving active treatment like high-dose corticosteroids or chemotherapy, or transplant patients who are receiving immunosuppressive drugs, people who are severely immunocompromised, and people who are receiving biologic agents, means almost everybody with lymphoma and leukemia, they have to receive the third dose of COVID-19 vaccine. My presentation finished. If there is any question, I will be happy to answer, and I stop sharing my slides.
Wonderful. Thank you very much, Dr. Hosseini, for your excellent presentation. And thank you so much for thoroughly addressing the impacts of COVID-19, as well as vaccine information for lymphoma and CLL patients. As you have mentioned, there is a lot of research now coming out, which is great. So that provides a little bit more guidance for this patient population. So we actually have a number of questions, which is great, coming through already. So I'll go ahead and start reading them out in order of receipt. So the first question that we have is, what is research showing about having a mixed vaccine series? So for patients that might have had AstraZeneca first and then got Pfizer, are there any sort of comparison studies on, the long-term efficacy in these patients that have mixed dosing versus two of the same doses of the vaccine?
Exactly. There are multiple studies, and it seems that this is true, and we call it as heterologous types of vaccination. It means people get one dose of, for example, Johnson & Johnson, and then they receive Pfizer vaccine, or different types of protocols were tried. I think it is true, and the people who received heterologous types of vaccines, they appear to have a higher rate of response to vaccine. We have some preliminary data. I saw one of the studies that just published last night before this presentation that showed a higher rate of immune response, and probably NACI in Canada will release something soon to suggest these types of vaccination. That's correct.
Oh, okay, great. Thank you so much. I guess the next question, and I'm not sure if there have been any, head-to-head comparison studies, but what vaccines shows the best safety and efficacy for lymphoma and CLL patients? Has there been one between the different vaccines? Have there been these studies?
As you said, there is no head-to-head trial to compare different vaccines. Most data in patients with lymphoma and CLL are limited to mRNA vaccines like Pfizer and Moderna, and most of our experience are with these two vaccines. However, it is important to know that receiving other types of vaccines is also safe, and we don't say you have to specifically receive Pfizer vaccine, but because of the small number of patients who were included in those studies, and specifically when you look at patients with underlying lymphoma or CLL, there are a group of patients that they're receiving different types of treatment, and we have to look at the effect of those treatments too on the response to vaccines. So it may not be true if we say generally patients respond to vaccine with this specific rate if we don't look at all other variables.
Okay, wonderful. Thank you. So the next question we have is related to a specific situation. So this patient has had 2 vaccines, but actually recently was tested positive for COVID about less than a month ago. Mostly felt okay, felt like a cold, and is doing fine, and is wondering at this point if they should, get the 3rd vaccine, as being asked of them, if and whether or not they with getting the virus have built up immunity now to it, and whether they still need the vaccine.
Exactly. Thank you so much for this question. So, as I said, when you get COVID-19 vaccine, it is possible that you get symptomatic illness, with COVID-19. We just reviewed in my slides. It is possible you get fever, you get sore throat, cough, but the rate of hospitalization, going to ICU, intubation, and mortality is much, much lower than people who are not vaccinated. This is important. And when you get vaccine and you get infection, of course, it builds up your immunity. You will be more immune compared to other people, but still we recommend to get the 3rd dose of vaccine regardless of your infection. But please talk to your doctor to look at the intervals and other variables. They will let you know about the best time that you can get the 3rd dose of vaccine.
Perfect. Thank you so much.
No
the next question we have is related to certain lymphomas. Some lymphomas don't actually require treatment right away, and these patients will enter in what's known as a watch and wait or active surveillance phase. For those that are in this watchful waiting approach, how much protection would the vaccines give, and should they receive all 3 doses of the vaccine if recommended by their doctor, and are they eligible to receive all 3 vaccines?
Exactly. People who do not receive treatment, there are 2 groups in previous studies that were done. One group was people that they did not respond to previous treatments, and they are waiting to see what options may be available. In those individuals, the response to vaccine was low. But people who had some response, or they were waiting to see what options may be available, and the cancer is not progressive that much, their response to vaccine was much, much better than people who were getting chemotherapy or getting treatment specifically. Because when you are getting active treatment, it affects your immune system function, and your response to vaccine may be poor. I just want to mention one thing that we all have to consider. If your antibody response is low, it does not mean that your protection is also very, very low, because we still don't know the meaning of those numbers. It needs a lot of research still to see, when we say 10% higher rate of antibody, what does it mean? These are those tests that we use for research. As I said, many of these tests are not standard yet, but it appears overall, when multiple studies show this, that the immune response in lymphoma patients are lower. But when we say antibody response is lower, is not necessarily meaning your immune response is 100% lower. No, it's probably, it has some effects, but we cannot quantitatively say how much.
Wonderful. Thank you so much for clarifying that. The next question we have is actually, or it's a 2-question part, and it's related to CD20 therapies. As I know, research I think has been published on this. So the first is, if having received a type of CD20 therapy like rituximab, many years ago, let's say 3+ years ago, would that patient still have sort of a lower vaccine response compared to what the general population would have? And then the second part to that question is, if currently on a type of CD20 therapy, is it recommended to still take the vaccine? And I'm sure part of that question will have to deal with speaking to your doctor to get the recommendation.
Exactly. Thank you for this question. People who are getting anti-CD20 therapies like rituximab or obinutuzumab, for example, they are more likely to develop a lower response to vaccines. Some data showed 13% is very, very low. Like, the response to other vaccine is also low, like hepatitis B vaccine, for example, I don't know, other vaccines, and a suboptimal response to vaccine is expected. However, it is important to know that the effect of rituximab maximally remains around 6 months later in terms of effect on the B cells. There are some minor effects even longer. Do we recommend them to get the vaccine? Every single patient has a specific treatment plan for lymphoma and vaccination. It is better to review the best time for vaccination with your doctor. I don't want to give any specific time for vaccination. For all of our patients, we look at everything, their blood test result, the course of illness, their response to treatment, and then we recommend vaccine.
Okay, wonderful. So I think we have probably just time for about one last question, and that actually relates to what you were just saying. Of course, when the vaccines were being administered due to some delays that we had in Canada in getting the vaccine, there were delays in receiving the second dose of the vaccine compared to the first dose, and it wasn't that 28-day or 21-day as per the clinical trial research has shown. So I guess the question relates to, with this third vaccine that's now becoming available for patients, is there any timing, that shows the best efficacy? Is it better to get it as close to the second dose in those people who haven't received it yet, or should they just receive it as soon as it becomes available to them?
Exactly. As I mentioned in my slides, we recommend that at least 28 days after the second dose, people get the third dose. Okay. However, some recent data, it shows even if you get, with a longer interval, your response to vaccine may be better. We don't know still what time is a better time, but definitely we don't recommend sooner than 28 days. It is not, terrible if you get your vaccine maybe 2 months later, 3 months later. It is still effective, and who knows, it may cause a higher response, in your immune system function, because anyways, we are causing more stimulation of your immune system to see the antigens of the virus and produces some immunity.
Wonderful. Well, thank you so much for taking the time to thoroughly explain and answer all of those questions. I'm sorry if we were not able to get to your questions today. Please feel free to send your questions directly to us at info@lymphoma.ca, and we will try to get to them as soon as possible. I wanted to thank you so much, Dr. Hosseini, for taking the time to share your expertise and knowledge on COVID-19 and the vaccine with our patient community. And thank you so much to the audience who attended this live session and were able to ask their questions.